Hello everybody, I am Dr. Diksha Pandey and you are watching Urogynecology for Beginners. Today's topic is sling surgery for prolapse. And the disclaimer is, I do not do these surgeries. But it is important for all those who are practicing gynecology, urogynecology and are students in the same specialty must know these procedures. Number one, that we have to understand the history, how we have evolved. Number two, it is an important question for exams, so you all must be able to answer in exams. And third, you never know, these principles might ignite a spark inside you and you might come up with one mind-blowing idea and transform one of these procedures and innovate a new one. Who knows? So, watch this video, understand the concept and basic principle and also the problems related with these procedures and then decide whether you want to do it or not.
Uterine preserving surgery is the name for those surgeries in prolapse wherein the uterus is not removed, yet somehow pelvic organs are placed in their normal anatomical position. Trust me, uterine preservation is an option for women of all age groups who have prolapse, though the goals of preserving uterus are different. Like when the lady is young and nulliparous, the goal is preservation of fertility. While in young women who have already delivered children, the goal is more of psychology related and reduction of risk of complications related to hysterectomy. In old and debilitated women, the goal is to decrease surgical morbidity. Today, in this lecture, our focus is only the first group, that is, young women who are keen on fertility. Remember, for fertility, uterus as well as cervix both need to be preserved. The idea here is to pull up the uterus so as to restore anatomy. Most of these surgeries are performed abdominally, either via an open or laparoscopic approach. Broadly, these surgeries can be divided into three groups: sling surgeries, Nadkarni's operation, and mesh hysteropexies. Among the sling surgeries are Shirodkar sling, Purandare sling, Khanna sling, Virkud sling, and Soonawala sling. About all of this, we will be learning today in detail. And after that, we'll be discussing the basic principles of Nadkarni's operation and also about mesh hysteropexies. So, sling surgeries first. There are 6 kinds of sling surgeries for prolapse repair in nulliparous women desirous of fertility: Shirodkar's, Purandare's, Khanna, Virkud, and Soonawala. Joshi's sling, it is written in white because originally it was meant for suspension of vault prolapse. When we talk about sling surgeries, I think this is the most important slide which all of you must understand. It is a proud thing for us to realize that the sling surgeries for prolapse were invented and propagated by Indian surgeons over 60 years ago. However, in the dearth of two things: suboptimal follow up and not enough publications, these procedures didn't get much popularity on the global platform. The basic principle behind these slings is to reconstruct or strengthen the pelvic ligaments so that the uterus is kept back in its normal anatomical position. The key concept you must remember here is that in all sling surgeries, what we are actually doing is reconstructing or strengthening one of the pelvic ligaments, like uterosacral ligament, McInrod's ligament, or rod ligament. That's it. If you can remember this much, you understand sling surgeries. The first sling that was innovated in 60s is Shirodkar sling. It is an abdominal procedure. The principle is to recreate, remember, uterosacral ligament. How do you remember Shirodkar sling? It is easy. Always remember that Shirodkar sling attaches the uterus or the uterine cervix to the sacrum. It makes uterosacral ligament. To create the uterosacral ligament, the sling, what we call is the muslin tape. On the right side, when you have to do it, it is very easy. So first you attach it to the posterior aspect of cervix above the confluence where the uterosacral ligaments join in a V-shaped fashion, and then pass it through the retroperitoneum. With the help, when Shirodkar used it, he used a semicircular sling handle, but you can use a curved cockers or a curved clamp also. Then finally, after taking it behind the peritoneum or beneath the peritoneum, you reach the sacral bone near the sacral promontory. Dissect the peritoneum and expose the entire longitudinal ligament and attach this muslin sling to the entire longitudinal ligament over the sacral promontory. On the right side, it is comparatively easy to perform. The problem is the left side, because as you can see here in yellow color is the sigmoid colon. So if the sling is very close to sigmoid colon, the hypothesis is that it might hurt or erode the sigmoid colon with constant friction. So idea here was to make a loop on the psoas major muscle and pass the loop on the left side through this loop and then take it to the sacral promontory, ultimately fixing it to the entire longitudinal ligament. I will repeat it once more. What you have to do, you take a muslin tape and the middle part of the muslin tape, fix it at the cervix just above where the two uterosacral ligaments are converging and making a V. From there, half will go to the right side and half will go to the left side. Right side is easier because there is no sigmoid colon here. So take a helical instrument or take a semicircular instrument, which can be, in simple words, a curved clamp. Pass it just below the peritoneum and reach the sacral promontory. Here you have to dissect or cut the peritoneum so as to be able to see the entire longitudinal ligament and fix that end, the right side end, there at the sacral promontory onto the entire longitudinal ligament. On the left side, it is little bit tricky because of the presence of sigmoid colon. So separate the sigmoid colon, take a loop with proline suture on the psoas muscle, loose so that it makes a loop, pass the muslin tape through the peritoneum first, then pass it to the loop on the psoas major muscle which you have made, and then again take muslin tape to the sacral promontory where you have dissected and opened the peritoneum and fix it at the entire longitudinal ligament. If you have understood the procedure well, you only can tell what are the negatives of this procedure. It is technically not a very easy procedure to perform. There is a risk of injury to presacral veins, external iliac vessels, ureter, sigmoid colon, nerve trunks to the retroperitoneum, and later there can be a risk to bowel erosion or obstruction if the psoas loop comes out. A further disadvantage is that the cervix is pulled posteriorly towards the sacrum, changing its normal anatomical location in the vagina, thus increasing the risk of cystocele or the entire compartment defect. Keeping in mind all these problems, Purandare innovated the entire sling. Easy to remember, P for Purandare and P for pubic symphysis means the sling which is directed towards the pubic bone. Actually, in the original procedure, Purandare did not use a muslin tape. Rather, he created two strips from the rectus sheath which were dissected on the two sides. With the help of a suture from outside, these strips were negotiated through the deep inguinal ring along the round ligament, and then finally they were fixed onto the entire part of cervix at the level of internal os. But later, making it more easy, a muslin tape instead of rectus sheath was used. In here, what we have to do, cut the UV fold, deflect the bladder down, and then attach the muslin tape onto the entire surface of cervix, which is taken along with the round ligament and then finally attached to the rectus sheath. Though technically it is a simpler procedure as compared to Shirodkar, but it has its own risk of retroversion of the uterus and thus of introcele. The third kind of sling is called Khanna sling. Here the idea is to recreate the cardinal ligament. K and C sometimes are used interchangeably, so you can remember Khanna sling is for cardinal ligaments. Here again, a muslin tape is used which is attached to the posterior aspect of cervix, where actually the cardinal, maximum part of cardinal ligament is attached, and from there it is taken to the ASIS or the anterior superior iliac spine, which you can easily feel in your body. Now also try it. Felt it? So as expected, the tape here becomes very superficial, which can be easily felt by the patient. And there are risk of periostitis as we are attaching it to the periosteum of the bone, and sometimes the tape may get detached also. Next is the Virkud sling. I call it a smart sling. In here, the easier side, that is the right side, uterosacral ligament is reconstructed. On the left side, where uterosacral is difficult because of the presence of sigmoid colon, reconstruct the round ligament. Thus, in a way, it is a combination of Shirodkar and Purandare. Now understand one more concept here. Where the sling is attached to a bone, it is fixed, or in other words, static. Whereas the rectus sheath is mobile with activities and respiration, so the sling which is attached to the rectus sheath is called a dynamic sling. Because Virkud sling is combination of right side static and left side dynamic, it is also known as a composite sling. Then came the Soonawala sling, which is even easier, only on one side, right side, which is the easier side for uterosacral ligament reconstruction. He also suggested just the plication, not putting the sling, just the plication of left-sided round ligament to hold the uterus in place without much distortion of the normal anatomy. For the sake of completion of muslin slings, I have also included here Joshi sling, which is basically for wall prolapse, and here the pectineal ligament is the point of anchor. The question now is, despite having around 10 slings with their various modifications, why are we not using them commonly? The answers are two: lack of publications and need of long-term follow-up data. You have to understand, if you are doing an operation in a lady in her 20s and early 30s, she has around 70 years ahead of her. Before gathering the courage to perform these surgeries, we need to have some long-term data on efficacy and more on the risk of complications, isn't it? After a description published in 1967, only two publications I could find out, both in Foxy journals and both just review articles. One more question that creeps in mind is that okay, fine, people who invented it for some reason did not publish. But why no one else in the world tried to conduct a good interventional study with sling surgeries? You may find the answer here. Before the 1980s, muslin tape, which is a polyester material, was used in various surgical procedures, including the repair of prolapse. It was favored over the autologous fascia because of its durability and strength. During the 1990s, increasing awareness of the complications like infection, erosion, chronic pain associated with muslin tapes began to emerge. These complications were attributed to the tape's small pore size, which impeded tissue integration and promoted fibrosis and infection. The development and adoption of macroporous mesh material, such as the one we use today, polypropylene mesh, marked a significant improvement in surgical outcomes. Studies demonstrated that macroporous meshes allowed for better tissue integration, reduced infection rates, and had fewer complications. The larger pore size of macroporous mesh facilitated the growth of host tissue into the mesh, promoting stability and reducing the risk of complications. With the penetration of these macroporous polypropylene mesh in urogynecology, new procedures were innovated. These are called hysteropexy or cervicopexy, when the uterus is retained. You know these procedures very well. When we do it for wall prolapse, we call it sacrocolpopexy. The idea is the same, lifting up the uterus towards sacrum with a much stronger and regenerative kind of attachment. To complete the list of uterine preserving surgeries for prolapse, a word about Nadkarni's operation. It is a kind of cervical amputation where only the supravaginal portion of the cervix is removed. The uterus and remaining part of cervix are then anastomosed. It is technically not easy, and again, we don't have sufficient follow up data to adopt in day to day practice.
So I hope you understood what these procedures are and you will remember it now. But I have one point to make here, that whenever you are managing a patient or going to the operation theater, always remember that it is not a talent show. It is not that what difficult surgery with what bravery and how nicely you can do. It is about your patient. Keep the patient in the core of your thought process and think how this patient can be managed best, giving her the most optimal efficacy with least side effects, improving her quality of life. If you will keep these things in mind, your practice becomes very easy and effective. Thank you.